Okay. Here, wait a minute. Just 1 second. Let me go back to reset it. Okay. Put this guy over here. So when I was trying to set this part up, this is not, again, an anatomy physiology class, okay? Just, so I'm gonna go through, let me see, let me make sure you're seeing what I'm seeing. Okay, so we're gonna go through, this is from your Giddens book. These slides are taken right from the book. So this is basically saying this is what reproduction is. So understanding what the concept is, we're going to notice risk factors that place individuals at risk for reproduction problems, recognize those individuals who's having problems with reproduction, and then talk about nursing interventions and collaboration. That last part will be covered really in your case when you think about it. Okay, that's what I'm going to ask you to do with those. So there's two main types of reproduction, sexual and asexual. Asexual reproduction, basically it's an organism that can create a genetic copy of itself, and we think about viruses, we think about COVID-19, right? Some plants can reproduce also through this process, fungi, etc. Sexual reproduction is a biological process in which the combination of genetic material from two sources, so if we think about for humans, male, female, are needed. So mammals, fish, reptiles, plants produce through this process. So this concept analysis is to present the concept of reproduction that applies to humans. Okay. Key terms, and I'm not going to go through each one of these, sorry, but these are some key terms that relate to the concept: conception, contraception, sexual intercourse, ART, assistive reproductive technology, fertilization, germ cells, gestation. So for women, the scope is in two states, right? The non-pregnant state, the majority of life for a female is spent in a non-pregnant state. All individuals in a non-pregnant state represent one of two variables. Either they're not pregnant by choice, or they're not pregnant because something, not by choice, basically. So not pregnant by choice is relatively simple. This is your represented by a man and a woman, sexually engaged couple who are capable of creating a pregnancy and just basically are using contraceptives to avoid pregnancy. And some achieved through contraceptive measures or sexual abstinence. So by contrast, the not pregnant not by choice are individuals or couples who are unable to create a pregnancy regardless of whether pregnancy is desired or not. And that is broken down into three different categories. Individuals who have not yet reached sexual maturity. So you're young adolescents, I shouldn't even say adolescents, children really, and are infertile. So, and this also includes, this group includes women who have reached menopause. Those who have reached sexual maturity but are fertile but partnerless. I think that's it. So pregnant state, the other state is pregnancy, that represents individuals or couples who intentionally create a pregnancy. and those experiencing an unplanned pregnancy. So pregnancy, obviously, it starts at the conception to birth or pregnancy termination. Again, I'm not going to go through each one of these. This is reproductive system anatomy and physiology. If you don't know what one of these means, you might look it up just so that it helps you. I mean, I'm sure you've learned it along the way in anatomy and physiology, but just as a reminder. I think I have wait. I am going to go in, oops, sorry. So just, this is going to cover physiological processes, and I'm just going to actually go to here. Are you guys able to see this?
Yes.
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 Are you cool with me showing you this right now? It's not very long.
Yes.
Yeah.
Okay. All right. Can you hear it?
No, we can't hear it. The way you fix that is you have to turn off your screen share and then go to turn the screen share on again. But at the bottom of the window where it asks you what you want to share, there's a little button that you click to say share my computer sound.
So stop share.
Yeah, stop the share and then go to
Okay.
share again. And when that window pops up, there's a little button at the bottom that says share my computer sound.
Thank you very much.
We're going to talk about early embryogenesis.
Now you can.
Say you're an egg cell, and you have
Yes.
this nice outer glycoprotein coat called the zona pellucida, and you've got your plasma membrane just inside of that. And a sperm has made its way through the zona pellucida and managed to get in through your plasma membrane and merged its genetic material with yours. You're now called a zygote, and you'd like to go on to form an embryo, but not much is going to happen when you're stuck as a single cell. And so what you've got to do is divide into multiple cells, and you've got to do it fast. In fact, you've got to do it so fast that you don't have time to grow. So you actually just split into 2 cells. And this process of splitting without growth is called cleavage. And you do this a number of times, dividing from 2 cells to 4, and from 4 cells to 8, all the while staying within the zona pellucida. So you've gone from 16 cells to 32 cells, and at this point you look different enough that somebody decides to give you a new name. So instead of being called a zygote, you're called a morula. And morula is just a Greek word that means mulberry, and you actually do look a little bit like a mulberry. So,
Oh, sorry. Oh God.
The different cells within the morula start to get closer and closer together. And in fact, the cells start to get a little bit different from each other too. And you notice that these cells on the outside are a little bit different. I'll draw them in here a slightly different color. And we can tell them apart, and this process of being able to tell cells apart as they become different things is called differentiation. So here we have 2 separate populations of cells. This one on the outside, we'll call them trophoblasts, and this mass of cells on the inside we'll call embryoblasts. And so you're going to continue with your process. We'll move on to the next stage, and we'll draw our zona pellucida here, and we'll draw all of our trophoblasts along the outside here. Another interesting thing is happening to those cells in the middle. They're starting to clump even more. In fact, they clump so much that they all cluster at one end, leaving a little cavity on the other end. So here you can see your trophoblasts and your embryoblasts, this mass of cells in the middle. Some people actually call that the inner cell mass, and it's left you with this cavity, and that cavity is called a blastocele. Now, again, you're starting to look a little bit more different than you have in the past, so we're going to give you a new name. This structure that you've turned into with a blastocele and an outer cell ring of trophoblasts is called a blastocyst. In fact, we name this whole process after you, and after cleavage, the process is called blastulation. So also about this stage in blastulation, your zona pellucida starts to disintegrate away. Here I'm going to draw a little bites being taken out of it here as it falls away and disintegrates. And that's going to be important later on because you can't be stuck in this thing forever. And the next step in blastulation, you actually just lose it completely. So now we'll draw our trophoblasts completely naked without a zona pellucida. But more interesting things are happening to you. Your inner cell mass of embryoblasts is starting to look a little bit different. So you still have this rim on the outside here up at the end of your blastocyst, and you still have this mass here in the middle. But you've developed another cavity, and this cavity is called the amniotic cavity. And also, your inner cell mass of embryoblasts has started to differentiate more. And now it's got this layer on the bottom of it here, and the cells in this layer are called hypoblasts, while the cells in the layer just above it are called epiblasts. Now at this stage, we're pretty much completely free of our zona pellucida, and that's going to be really important for implantation. But that's a discussion for another time. We're going to focus on this ball of cells here. And I really want to stress that this is a ball of cells. It's not flat like we've got it drawn here on the computer screen. It's three-dimensional. It's spherical in nature. A spherical melon. So think of it like a melon. Here I'm going to draw a spherical melon. So now I want you to picture taking a big knife or a machete or something and just slicing the top off the melon like this. Here we'll erase the top part of our melon here, and we're left with a flat surface. So now that you've got a melon with a flat surface, picture yourself taking a pancake and just putting it right on top of this flat surface like that. And that's basically what we've got here with our blastocyst and this forming layer of epiblasts and hypoblasts. It's really a pancake. It's not two-dimensional here. It's a three-dimensional disc of tissue. So we're going to draw this again, but this time without the outer sphere of trophoblasts. But we're going to draw our pancake of epiblasts and hypoblasts. And what you can see here is our pancake has got two layers. So in fact, this is a very important structure in embryology called the bilaminar disc. And we're going to get another look at the bilaminar disc here. So I'll show you. We're actually going to draw a little plane through the disc here. And if we take a cut view through this plane that I've drawn, it looks a little bit like this. So this is still our bilaminar disc, but now we're looking at a slice through the bilaminar disc, as opposed to here we're looking at the entire bilaminar disc from the outside. So now we're looking at our pancake of our bilaminar disc here, and we notice we start to see something forming on the edge of it here. And that something looks like a little bit of streakiness that kind of splits our pancake right in two. You can think of it as pouring a little streak of syrup along the top of the pancake and dividing it into two halves. So here I'm going to draw it on the surface of the pancake, and then over here on our cut view, you can see that this little streak happens right about here in the middle as it reaches the plane of our image. And this streak of syrup on our pancake has got a name. It's actually called the primitive streak. And the formation of the primitive streak marks the beginning of the next stage of early embryogenesis, and that's called gastrulation. Now what that primitive streak actually is just the site where the cells in this epiblast layer of our bilaminar disc start to migrate. Here I'll draw the paths of the migrating cells. They heap themselves up right at the primitive streak, and then they start burrowing their way down into this bilaminar disc. And they go out into the hypoblast layer, and they just kind of go all over the place here. But it all happens from that primitive streak. So as the cells migrate out from the primitive streak, we can see that our structure has changed a little bit. Now instead of having two layers, one layer of epiblasts and one layer of hypoblasts, all of those migrating cells have now differentiated even further, and we're left with a layer of cells on the top, a middle layer of cells as they go out into the body of the bilaminar disc, and we still have a lower layer of cells down here. And so now you can see, instead of the bilaminar disc that we actually have a trilaminar disc. So we have three layers, 1, 2, and 3, and these are actually called our germ layers. So we have a single layer on top, and instead of epiblasts, this layer is now known as ectoderm, and our middle layer is mesoderm, and our lower layer is endoderm. And cells from these 3 layers go off to do very important things, and each layer forms its own specific structures. So that process of the formation of the 3 layers is called gastrulation. Once our 3 layers are formed, we can move on to the next step in embryogenesis, and the next step is called neurulation. So we'll draw our 3 germ layers in. We have a layer of ectoderm on the top. In the middle, we have a layer of mesoderm. And then on the bottom, we have our endoderm. So this final stage in early embryogenesis is called neurulation. And as you might expect with neuro in the name, we're going to see some neural elements formed here. And now we have our trilaminar disc with our 3 germ layers. And in the middle of the mesoderm, the central layer here, we start to have further differentiation of cells. And right in the middle, we get this cord that starts forming. And I'm going to draw it as a little purple dot here, but what that really is underneath where the primitive streak was, mesoderm cells are differentiating into a cord structure, and that's called a notochord. Now in humans, the notochord doesn't go on to do a whole lot. It does form part of the intervertebral discs, and very rarely it will cause a tumor called a chordoma. But in general, its main goal and its main purpose is here in neurulation. Now, this differentiated bit of mesoderm actually induces a change in the ectoderm above it. So here we get a change within the ectoderm. I'll draw that in as kind of a thickening of the ectoderm right here. And that thickening in the ectoderm has a name. Since it's kind of plate-like when we look at it in section here, this is called the neural plate. Now we have our notochord formed and we have our neural plate formed. The next thing that happens, so we'll redraw our 3 layers here, our ectoderm, our mesoderm, and our endoderm. And here at the bottom we have our notochord forming within our mesoderm. And right above it, those neural plate cells actually start to dive into the mesoderm. And as those neural plate cells dive in, they start to form a ring structure. And actually, since this is a 3-dimensional thing, this ring is more like a tube. So you can picture this tube going off into the rest of this pancake that we've drawn here. And as this neural plate zips up and dives down into the mesoderm, it becomes known as the neural tube. Now, this isn't a perfect process, and as the neural tube is zipping up from one end of our pancake to the other, little cells are breaking off from the ectoderm and going out into the mesoderm. Now, these cells actually have a very important role as well, and will go off and to differentiate into their own special tissues, and these are called neural crest cells. So once we have the formation of our neural tube and our neural crest cells are diving off into the tissues and differentiating, and we have a pretty good idea of what the ectoderm, mesoderm, and endoderm are, our early embryogenesis is complete. So just to recap, we started off as a zygote.
Is that helpful? Did I lose you guys?
No,
Oops.
still here.
That was good.
Okay, all right. All right. I forgot that one was that long, but this one's shorter.
So it's been about a week since you've been fertilized. You used to be an egg until sperm found you. You went through a zygote stage and you cleaved, dividing into multiple cells, and you finally become a blastocyst. And you've been bouncing around in the fallopian tube for a little while, but you finally made it into the endometrial cavity within the uterus.
Sorry,
And
just
you
one
start
second.
bumping against this nice endometrial lining. And that looks like a...
Let me just, I'm gonna go on to, so you get the idea. This is at this stage, you can, listening to that, all of that was going on, you realize how important those first, wow, even that first week, right? The embryonic period is the stage between 3 weeks and 8 after fertilization. So during this time is when the differentiation of the body systems and organs start occur. So my thought was when he talked about the neural tube being formed, well, that's going to be the stage that a neural tube defect could start. right? So you can see how important these first few weeks are. And so a pregnant woman at this point, when you think about who's exposed to any kind of toxins, either by environment or by something she's taking, drugs, alcohol, tobacco, that this could, or if she gets infected, or I would even think at this stage, because we're all thinking about COVID-19, someone who might get COVID at this point during this embryonic development would seriously affect the pregnancy, I would think. So at the end of this period, the embryo has human features and is referred to as a fetus. So this is the main embryonic period. You can see my screen still, right?
Yes. Yeah.
Okay. So then this next period is called the fetal period, and that's between 9 and 38 weeks. And this is a nice graph because it actually shows you all the different things that can happen during this time, right? So neural tube defects, that first mental retardation, and central nervous system is being formed. So basically, when I think about this, I'm thinking about insults to oxygenation to the baby, which could include anything from mom got in a car accident, or mom has low iron, low hematocrit level, or maybe mom has preeclampsia. So this is a nice graph to kind of understand what's going on during this period. This here is formation of the heart. So ASD, VSD, TA, these are all things that are going on in the heart that's going to affect fetal circulation. All right. So now we can move on to, do you have any questions on that? I know that was a quick brief, and there's that other video that's in there that you can review. Anybody have questions? No? Okay, so variations, meaning when things go wrong with this, or wrong or just different in this concept, they are, well, infertility, which is defined not by being able to get pregnant despite having unprotected sex for at least 1 year. So it's difficult to calculate for a number of reasons. It estimates that approximately 15% of reproductive age couples in the United States are affected by infertility. And you know, there could be many reasons for that, right? You could just, people are waiting longer to have kids. So by the time they decide to have kids, that whole process of fertility may be, well, it is a lot older. So the other part is maintaining a pregnancy and optimizing fetal growth and development. This may be about 15% of clinically recognized pregnancies ending in spontaneous losses or miscarriages. And the majority of these losses occur before 12 weeks. And those problems can be multiple twins, triplets, and basically these are moms who you may go to look at her history and she could be a gravida 5, para 1, let's see, AB 3. What is that to you?
Gravida means she has 5 children.
So a gravida, she had 5 pregnancies. A para is what?
The number of kids
Live
she
birth.
gets.
A para is the number of times she delivered her cervix, this is how I always tell people, the cervix has gone to 10 centimeters, she has delivered an infant. Now, you still don't know by that parity whether that infant is alive or not alive. But then what is the A?
Abortion.
Abortion or miscarriages, right? So for her, she's a gravid of 5. She had 1 live birth. And then from there, you may see it broken down to term versus premature. But then the abortion is the miscarriages or therapeutic abortions. So those you can see those in the history and physical broken down also. So the other part to this is unplanned pregnancy. So most of the time pregnancy is an expected event, but unplanned pregnancy occurs when the contraceptive effort has failed, or there's been a sexual encounter, whether consensual or non-consensual. I am not going to stop us for this because I'm afraid we're not going to have time. Okay, so we're going to move through this. So noticing risk factors that place individuals at risk for reproduction problems. This is the part of when we get into the case studies that you're going to want to, you're going to utilize this part for that, okay? So populations that are at risk are impoverished populations and adolescents. Why do you think that is? Well, that's probably a silly question. Do you want to?
Sorry, maybe access or lack of access to healthcare, and then adolescents, maybe unwillingness for healthcare or being scared to get healthcare because of the repercussions or their parents possibly.
To ask for help with that? Yeah, good. Good. Here, so there are different factors: biophysical, psychosocial, socio-demographic, and environmental. So we won't break out into groups on this one. Can you identify some examples, beliefs and practices related to reproduction that are prevalent among members of different cultural groups? Sorry, let me back up. That's not right. Can you list examples of the individual risk factors for reproduction as you think about each one of these categories? So let's look at biophysical factors. These are individual risk factors.
Would that be like genetic concerns?
Yeah, that's what I'm thinking. Genetic.
Maybe something related to the physical condition of the mother.
Okay.
The book lists also nutritional concerns like malnutrition or diet.
Good, yeah. Now, how about psychosocial factors?
Like the mental health aspect of it, maybe stress.
Having a support team.
Having a support team. You guys talked a little bit about these in the conference you just were at, right? Did you talk about this? Psychosocial factors?
Yes, we did.
What was that? Pretty much what people have already said? What other things are you thinking?
They also mentioned, you know, like the relationship of the mother that they're in, whether it's an abusive relationship.
Good. Yes. Yeah. Socio-demographic factors. What does that mean?
Is that like their economic or their social status type thing?
Yeah, I'm thinking it's you know, somewhere that basically where the woman lives is in an area where maybe access to healthcare, access to nutrition, access to ability to what do you call it? Transportation, and environmental factors. What comes to mind on that one?
Environment, the book states, excuse me, environmental factors can be like industrial pollution, radiation, chemical exposure.
Yes.
Living by
Good.
the
What? Sorry.
living by the fields.
Say that again.
I said living by the strawberry fields.
Yes, exactly. No, that's true. What's in the water supply right around there? What's in the wells? So now we're going to talk about recognizing that individual who has problems with reproduction. And this goes into where we probably see this person for the first time, right? So we're talking to her and we are asking her about present and past health history. So that could be how many pregnancies has she had? Has she been trying for a long time? Is this an adolescent who had sexual intercourse once and now is pregnant? Okay. Family history. Here I think about if she has had pregnancies or has had infants or babies before, did she have preeclampsia with those? Did she have gestational diabetes? Does diabetes run in their family? That's kind of the things, you know, you really ask them about their genetic history if they know that, right? Some people come in and are very familiar with their genetic history because perhaps there's a problem or there's an issue. And so they come in knowing that from the beginning. Talk to them about their menstrual history. How old were they when they had their first period? And are they, well, if you're talking to someone who's pregnant, she probably isn't in menopause, but I guess she could be starting it, but any problems with menstruation, and then the pregnancy history. And again, this here, and this whole acronym has evolved over the years. When I first started, it was gravida, parity, and you might have abortions. That was all there was. Now this is gravida, term pregnancy, preterm, abortion, and number of children that are living. And then you'll even see sometimes they'll break it down even further. Another part as you're taking the history is asking them about sexual history, any kind of problems with this, if you're talking to the male, if this is a couple, erection, libido, any kind of history of sexually transmitted diseases. You're going to want to know if the person has had a history of syphilis or gonorrhea, HIV, okay? And problems with uterine support, any kind of problems that they know of that they've had. So again, so this is asking in your learning group, identify the history and clinical examination findings that would be indicative of reproduction problems. So let's just talk about these right now. Sorry, because we're at noon. What are some history and clinical examination findings that you might say, this person could have some problems with the pregnancy or getting pregnant?
Are you talking in relation to like preeclampsia or like gestational hypertension in the past or something?
Okay.
Are you asking just for getting pregnant in that aspect, or
Say that again, Shannon.
are you asking like in just the circumstance of trying to get pregnant or difficulty getting pregnant?
I think they're even looking at what kinds of things like red flags as you're talking to. See, the way they're kind of almost showing it too is they're talking about possibly this is a couple that comes in. Maybe it is a couple that comes in and you're talking to them both about their history.
I see. So maybe
So go ahead.
maybe some kind of history of like uterine cysts or something like that. Like
Maybe
Good.
endometriosis or fibroids.
Good. Yes. Yeah.
Perhaps
and-
she
and-
had. Perhaps if she had a couple of miscarriages, if she never got a DNC or a DNE, that can cause some problems too.
Good. Yes. And going down that path, who said that? I didn't see that.
It's Abram.
Abram, going down that road, you also want to talk to them about, so was that you had an abortion or a miscarriage? Did you go to the doctor after? Is she Rh negative? So did anyone, did she have any labs done at that point? Did she get ROGAM after the miscarriages? Those are all things that could be little red flags that this could be a problem with the pregnancy or produce some problems. So we're going to diagnostic tests. This is the reason why we're giving you the quiz is so basically you're going to go through these things. Okay. You're going to want to understand how do they do the pregnancy test? What is a CBC? Why is it important to know her blood type, Rh factor, rubella? So all of these are the type of things that are going to be on your quiz now, or survey, quote unquote. Now, that being said, I pretty much they're taken directly from, I went back to, what's the chapter in McKinney? I want to say 15, chapter 15 in McKinney. So now we get into some nursing stuff, right? What are appropriate nursing and collaborative interventions to optimize reproduction? Obviously, education, teaching about safe sex, what are different contraception methods, obviously avoidance of smoking, alcohol, any kind of drug use, and understanding nutrition. Are they already diabetic or are they overweight? They have a high BMI to start. These are all things that you want to talk to the person ahead of time. So so your secondary prevention screening, secondary prevention, okay? This includes prenatal care monitors that progress the pregnancy. And those of you who have already been in the OB area, have you already started hearing this kind of, I'm sure you've heard about the blood pressure, edema, talking about fetal heart rate, looking up labs. Have you gotten a chance to get into the chart and really look at some of this?
Yeah, we looked specifically at you know, the blood type because we were doing a discharge. So we looked at, you know, the baby's blood type, the mom's blood type. We're able to go in and make sure that she had her rubella. And then the other patient that I had was severely preeclamptic. So we did the blood pressure checks hourly and that sort of thing.
Good. Good. So this is your, I have case study number 2 because it kind of attached to this chapter. All right, so I'm gonna leave it at here, but this is your patient number 2 and I'll explain further as we go into lecture, but this is where you're gonna find information on her and also in your book, okay? But I have questions at the end of this that are gonna go over this, okay? All right, let's take, can we take 5 minutes, guys? Are you good with 5? Okay. All right, take 5 minutes. And so that'll put us back here like 12:10. That sound good?
That's good.
Okay. Thanks.
Christian, can you help me with that?
Okay.
Can you push mute on the screen right there? Push mute.
You guys almost back? 2 more minutes, huh?
I'm ready to go.
All right. Who was that?
Getting ready to go.
Who was that? Abram?
Oh, no, Alfredo.
Oh, Alfredo. Okay. I don't know you guys as well, so I gotta keep asking your names, okay? Hi. Okay, so what do you think, guys? You ready? Alfredo's ready.
Yeah.
Whenever you're ready, I'm ready.
Okay, so I know this is jumping around, but I couldn't figure out how to like start the lecture with something other than just producing a case study to start off. So this particular case study about Jenny Brown is going to be more of let's see. This case study is more of a well, as I'll play the thing for you, but so she's earlier in pregnancy. It does kind of start going into more of a mental health part. And this has to do, she is a vet, and so she's 30 weeks pregnant. IUP is intrauterine pregnancy, so typical pregnancy up to this date. Female fetus has a cleft lip and palate that was diagnosed by ultrasound at 18 weeks and confirmed to be present at 24-week ultrasound. So we will go ahead and I'm going to play you. Did anyone listen to the monologue of this already, or did you not see that? So let's go ahead and just listen. And I think I should still be okay, but let's.
Hi. Thanks for coming to talk to me.
Can you hear it?
Yeah. Oh, not no more.
Oh.
I'm so excited.
Let me make sure. Are you hearing it?
No, I can't. Hugo, help her out.
Do I have to go back and do that again?
Are we supposed to be seeing your screen right now or just hearing the audio?
Just hearing the audio.
Yeah, because the only way that you can share the computer audio with us is if we see your screen, I believe.
And you don't see my screen?
No.
Okay. Let me try
Negative.
that. Sorry. Let's see here. Whoops. I probably should have went back and did the. Let's see. New share. Share sound. Okay. Let's try that again.
Hi.
Now?
Thanks for coming to talk to me.
Yes.
Yes.
Probably heard what happened to me yesterday during my ultrasound.
You're hearing it, right?
Yes.
Yeah, we can hear it.
Yes.
Okay, sorry.
Hi. Thanks for coming to talk to me. You probably heard what happened to me yesterday during my ultrasound. When I found out that the baby was a girl, I was so excited. Then, when I heard she had a cleft lip and palate, I just lost it. I can't believe they had to tie me down to the bed and give me an IV. My heart was just pounding in my chest, and I thought I was going to vomit. I feel so bad for Eric, my boyfriend. I'm about 4.5 months pregnant. We didn't plan this pregnancy, but we were both pretty excited when we found out. Now, with this news, I'm not sure how I feel. I'm studying construction management at the university. The GI Bill benefits are a big help. They pay for almost all of my school costs, and most of the other students in my program are guys who aren't really into hanging out with one of the girls, so I don't have any girlfriends, really. A few of the guys in my classes are vets, but they probably don't even know I'm a vet. No one thinks of that if you're a girl. About that thing that happened yesterday, it happened to me once before when I was out processing. I was in such a hurry to get home that I wasn't really focused on what was happening. It was a really stormy day, and there was lots of thunder and lightning. I heard this one loud bang, and BAM! It just hit the floor. I was just freaking out, and I could not stop crying. I was shaking so hard. I couldn't even stand up. And they took me to the infirmary and they gave me some kind of pills that helped me to relax a little. And I wasn't really okay until after the storm passed. That kind of stuff never used to bother me. But over in Iraq, sometimes we'd hear these huge explosions, and pretty soon we'd found out that a bunch of soldiers got killed from an IED, an improvised explosive device. Sometimes the booms were really close. I never got used to it. It changes you to be over there, and people around here don't really get that. You hear about some of the stuff that happens over there, but the news makes it sound like it's only guys. I have these nightmares where I am trapped in a building and I can't get out. And there are these explosions all around me and I just wake up in a cold sweat, and usually I can't get back to sleep. So I go out and jog or something. I don't really get enough sleep, but sometimes it's better not to go to sleep so you don't wake up with nightmares. Eric thinks I drink too much. But I quit as soon as I found out I was pregnant. I quit. I have to admit, I've been more emotional lately with the pregnancy, too. The least little thing makes me cry, and I'm pretty edgy. Eric has learned to tune me out.
So just start thinking about, what are Jenny's strengths?
She's not drinking anymore. That's a strength, I guess.
Okay.
And knowing what your weaknesses are is half the battle.
Nice. Yes.
She sounds like she has a lot of, I don't want to say financial support, but possibly financial support from her school that might help with healthcare or paying.
Good. Yes. Good. Okay. And what are you concerned about with her? These are questions you're going to tackle as small groups later, but what are you concerned about? She's your patient.
Her trauma.
Mm-hmm.
I'm concerned about the fact that she just recently stopped drinking. With all the stressors, there could be a chance for relapse.
Good.
I want to talk to her about that.
Good.
Sounds like she doesn't have much socialization, how many people to go to, and she's with coping, possibly some PTSD from that, maybe emotional stuff too.
Sure does sound like it. Yeah. Good. Okay, so now I'm going to play you her boyfriend's audio file.
Thanks for calling. I'll be coming to the hospital soon. Should have gone to that appointment with Jenny, but I'm working on this new job, and my boss said if I miss one more day of work, he'd fire me. We really need the money right now, and I finally finished all the welder apprentice training, so the pay is pretty good. Jenny's been wound real tight since she got back from Iraq. I wasn't all that excited about her joining the reserves in the first place. She figured she'd have a desk job, but she ended up in some pretty unsafe places. I know she saw some bad stuff over there. Now, most mornings, even now that she's pregnant, I wake up and she's gone, even as early as 5:30. She has a lot of nightmares and wakes up screaming sometimes. She goes out for a run or gets in the shower and just stands there until the hot water runs out. Seems to be something that calms her down a little. Now, there are some programs at the VA hospital she could go to, but she says that mostly it's all guys and they just drown her out. You know, sometimes I listen to those news shows about PTSD, and I think that's Jenny. She's got every symptom, nightmares, and she totally avoids going to any crowded place like the mall. She freaks out if there are loud noises or people real close to her. She's real jumpy, irritable, and cranky even with her friends. We had a lot of fights at first, but now I just lay low and try not to get her agitated. I keep hoping that with the baby coming it'll be better, but I worry a little bit about how it'll go. Now that we know there's something wrong with the baby, I hope she can keep it together.
Okay. Nope. So we already kind of, are there any more concerns about Jenny that you want to say?
Since she has a hard time with loud noises and people being around her, I would be concerned for her for when the baby's born and it is being fussy and crying and not stopping, and how she would be able to handle that, not only like for herself and her own mental health, but also to like help the baby accurately.
Good. Was that Grace?
No, that's Emily.
Emily. Okay. Good. Yeah. So this part of this case study, you could go in different directions here. And this is also meant to be used in a simulation, actually simulation type setting. But what I'm going to have you do at the end of this, you're going to take these and I'm going to introduce another case study. And as a group, you're going to go through these and answer some of these questions and kind of compare them. And obviously, even already, you see that she has some pretty unique parts to her history that you are going to be concerned about. And then also, what additional information do you need or wish you had? If we go, I can show you this part. Is there anything else that just get you thinking about what maybe that you'd want to know?
Do you have another screen? Is it her only history? That history that's up there?
Yeah, I think so. But if yes, I believe that is all they give us right now.
So this is her first pregnancy?
Yes.
Okay. I would want to know like family history as well, like and what their coping styles might be, what they plan for the future as far as like having time together as a family as well. It sounds like they don't have much time together. And then just maybe get a more in-depth history, like for her physical.
Looks like her parents are 500 miles away. That's a pretty far. I'm thinking, where is Eric's parents? Is there any kind of support there closer? So good. So I'm going to leave that one there, and we're going to see about our next one, okay? All right, so this part, we're gonna kind of hit on the health disparities. Is this making figure out how to introduce 3 different case studies? Is this okay? You guys
Yeah.
hanging in there? Okay, you're hanging in there? Okay.
Mhm.
So this part, we're gonna cover the concept of health disparities. And obviously when I ask you what is health disparity, without reading it, does anyone have something in their mind that just put it in a few words? So you can see there's a couple of different definitions, one from IOM, one from Healthy People 2020, which I'm sure there's an updated one in the 2030 that we can find. And then there's the one from NIH. They have 2 separate definitions. And they actually separate it between healthcare disparities and health status disparity. So looking at this, a healthcare disparity is a difference in access to or availability of facilities and services. So that could be, let's say, well, we'll get introduced to someone in this case study, but I'm thinking about maybe someone who lives on an Indian reservation. She's 17, she lives on an Indian reservation, and the nearest hospital is going to be 60 miles away. That could be a healthcare disparity because she doesn't have access to healthcare closer. And then there's the health status disparity, where there's actually variation in rates of disease occurrence and disability between socioeconomic and geographically defined population groups. So, and then there's the definition that healthcare, Health Resources and Services Administration recently came up with. And they basically are saying the absence of disparities or avoidable differences among socioeconomic and demographic groups or geographical areas in health status and health outcomes, such as disease, disability, or mortality. So all these terms and their distinction are necessary to understand the impact of what healthcare disparities means to our nursing practice. What are we seeing today with COVID? And along the lines of health disparities, health equity, what are we seeing?
I think a lot of people are kind of holding off on their appointments.
Because why?
Either they've been canceled because they're not like important enough or like emergent enough, or they're too afraid to go to the hospital, or they are out of a job and just don't have the money to pay for it anymore, or lack of
Okay.
health insurance because they've lost their jobs.
Okay.
So maybe an all around, just to add to that, maybe like an all around increase in health disparities related to those issues that Brittany said.
And you know, I think about, so our populations, Hispanic, Black Americans, right now are at a higher incidence of not only getting COVID, but dying from COVID, right? And so then you have to ask, well, 2 questions: why are they getting it, and why are they dying from it? And they're getting it most likely, you know, it could be any number of reasons, but we have different, you know, I think one of the first people I remember, and I don't remember what state he lived in, was a bus driver who, do you guys remember this? Who was extremely upset because people refused to wear masks on his bus. And I think it was like maybe 4 or 5 days before that, they had him on the news saying about this. And then I believe it was a short period of time after he died of COVID. So those are the kind of things. He was in a position, he couldn't just not go to work. And so it put him at a higher risk. So the scope of the concept, you see this probably in almost every chapter of the concept book, this arrow. So you have acceptable versus unacceptable. And in the middle, you have avoidable health disparities. So identifying situations or factors that affect healthcare disparities. And these are, so before determining existence of a health disparity, it is critical to examine if the identified difference is inequality or inequity. Some health inequalities are unavoidable. Since their underlying causes are biological variations or free choice, which make changing the health determinants impossible or ethically or ideologically unacceptable. Sorry. Other health inequalities are not only unnecessary and avoidable, but also unjust and unfair. So Whitehead's 7 determinants of health disparities are useful as attributes for health disparity. So this is, he said, these are the 7 determinants. I always feel funny reading stuff from here. So natural, biological variation, health damaging behavior that is freely chosen, the transient health advantage of one group over another when one group is first to adopt a health promotion behavior, health damaging behavior in which the degree of choice of lifestyles is severely restricted, exposure to unhealthy, stressful living and working conditions, inadequate access to essential health services and other basic services, natural selection or health-related social mobility involving the tendency for sick people to move down the social scale. So basically, as you get older, you're going to move down as we get older, we don't have as much money because we're not working, so you move down the social scale. So that is his. In Health Canada, determinants are, they see it this way, include income and social status, social support networks, education, employment and working conditions, social environments, physical environments, personal health practices and coping skills, healthy child development, biology and genetic endowment, health services, gender and culture. So these are some of the determinants that Health Canada sees as when they're figuring out health disparities. So what does healthcare disparity mean?
Like a difference in healthcare due to your some type of status or maybe your race or something specific.
Okay. Anyone else?
It would be when a group suffers like I guess like a lack of health care for some particular reason more so than another group, right?
Yeah, good.
So kind of to add on to that, kind of the lack or inability to access to services in a particular area or for a particular group.
Yes, perfect. Yep. How is it linked to the concept of a culture,
It's probably linked by that each culture has like a set of like values or morals or that incorporate in their daily lifestyle. So it actually could have like an effect on like accessing like resources or just being lack of a certain specific area like on health.
Okay, expand on that. You're touching on it.
Oh, okay. Let me see.
Give me an example.
Yes, an example would be like for diabetes, like for the Hispanic, it's a increase on, that's a health disparity on their culture because they're not, a good percent of them are not educated, or it could also be because of the education level. So it could affect them by not being knowledgeable of what resources or how to go about it. That could maybe be a possibility for that culture.
Good. Yeah. Where they live, is there access to fresh vegetables and fruit? Or is is the nearest place they can buy groceries, the liquor store at the corner, right?
Yes.
I'm also thinking of though, thinking along the lines of like how like some cultures have, go ahead.
I'm sorry, I was going to give an example that I just thought of, primarily, let's say for, Hispanic women or Hispanic women of a certain age, for them to talk to really any medical professional, not to say even a man, but a woman, even about like contraception and things of that nature. That's not something that's often even thought of or brought up. So, if it's not asked by the provider or the nurse, then oftentimes that could be a topic that's missed completely.
Good. Good. Yeah, maybe even not thinking they have to go to the doctor early on, right? So that you can catch some of these early on problems that are avoidable. So how as nurses can we minimize this?
I think education's a huge
They
part.
should.
Yeah, education, assessment, identification, education. Those are all good. So the next system that they introduced you to was the social ecological model that aims to explain dynamic interrelations among various personal environmental factors. So Bronfenbrenner, sorry guys, I apologize for not being able to speak clearly sometimes here. So 5 socially organized subsystems relate to human development: microsystem, mesosystem, exosystem, macrosystem, and chronosystem. So this is actually, this has actually been used in nursing research and practice in relation to researching health disparities, because it provides an understanding for the interrelationships between the individual and the other systems. And it can provide a perspective to identify health disparities at each system level and directions of interventions at each level. So for example, this model allows the nurse to identify cultural barriers in access to healthcare at the level of the macro system and to develop an intervention to tackle the cultural barriers to reduce subsequent health disparities. So this is just a visual for, they're saying, you know, in nursing research, this is used to help understand what's going on, how can we identify what those health disparities are along each area. Does that make sense?
Yeah.
So the next one is the structural constructivist model, and it's based on the assumption of dual nature of human existence. So I wanted to give you something a little more. So the model adopts the perspective that reality of life is based on mental representation by combinations of socially shared understandings within a society. So, and at the same time, the model adopts a structural perspective that people are constrained by their external structures in which they are embedded. So we talked a little bit about that, right? Where do they live? Where's the closest grocery store? Health disparities literature featuring this model asserts that the concept of race ethnicity is socially or culturally constructed with the underlying logic that when we can control the ways in which race ethnic groups differ, race ethnic disparities will disappear. Does that make, what do you think I'm saying there? When we can control the ways in which race ethnic groups differ, racial ethnic disparities will disappear. So this perspective or model strongly supports the idea of socially and cultural construction of race ethnicity that frequently results in health disparities. Oops, sorry. What's your thoughts on that? I'm not sure about this one.
Yeah, I'm a little lost on this one.
I quite honestly, people are constrained by the external structures in which they are embedded. The reality of life is based on a mental representation constructed by combinations of socially shared understandings within a society.
So constrained by things like the government laws, etc.
Or is it constrained by they were born and raised in this area and their great grandmother did that way, so now so it's not really I mean, in my head I'm thinking it's not really a could be structural, but it's more of a mental, or where they don't see another way to do it because that's the way it's always been.
So like cultural embedded, like they were raised that way. Like my mom thinks Vicks heals everything.
Yeah. My mom did too. Yeah. That's
Okay.
how I'm seeing this. Does anyone have a different way of looking at this?
That's kind of the same way I was thinking about it too. It's like
Okay.
you're so caught up with what you know and what you believe that you really don't have either like an understanding or like a concept that anybody else's could be completely different.
So you're kind of like closed-minded, not open-minded to other things.
Right, and it could be, I mean, to me, sometimes closed-minded seems almost a little negative. I think it's very innocent, you know. Hey, I was born in this farmhouse out in the middle of nowhere, and my great-grand, you know what I mean? So you never push yourself out of that. That's how I'm seeing this. These are different ideas of how to dive in nursing research, how to help define health disparities, and also what are those health disparities, okay? So then this one, cultural competence model, and sorry about the picture, but I was trying to like get you something that kind of gave you a visual, because I'm a visual person, you guys. Interpersonal interactions and organizational methods that can improve healthcare disparities. And they go into define it a little more. And this is on page 488 in your text. So cultural competence is understanding the importance of sociocultural influence on our patients' health beliefs and behaviors, considering how these factors interact at a multiple levels of the healthcare delivery system, and coming up with some interventions that take or incorporate these issues into your care, so that the delivery of care is high quality to a diverse population, not just the Caucasian 25-year-old woman who's here for her first baby, but maybe that that Black woman who is 20, who is single, or a Hispanic couple who's coming in for their first time, or maybe their third baby, or the woman who from the Army, because in my head, I'm even thinking someone who's a vet really comes from kind of a different culture, right? She's coming from a whole different base than what a lot of these other women are coming from. So recognizing the differences between avoidable and unavoidable health disparities. Avoidable and unacceptable disparities are, obviously, we've heard this, a lack of health insurance, the higher healthcare costs. I cannot believe how high healthcare costs are now. And language barriers, lack of transportation. These are all avoidable and unacceptable disparities. Okay. I'm going to keep going. And let me go to, so this is your third case study. So this is, she is a Joan, I think this is said Jones Antoinette. She's 21 years old, and she's African-American woman who visited an obstetric clinic for prenatal care. She, for her first time at 30 weeks gestation. Her baseline vital signs were normal. She was assigned a white nurse midwife for her prenatal care throughout the remaining of her pregnancy until delivery. Just tell me a couple things about this that you're like,
Her first time being seen at 30 weeks.
Good. What else? I mean, I think it could or couldn't be the white nurse midwife. I mean, I think that's implying that she couldn't give her the care that she would need, but that might be a barrier for her, right? And what about her age?
Very young.
She's young, young in standards of today, right?
Right.
So here, let's see, what time do we have? Okay, we do have a little bit of time. I think what I'm going to do though is so you see that this is her background here. So let me just pull up this other one so that you know what I want you to do, okay? Let's see. All right, so in your modules, you can see this, right?
Yes.
Okay. In your modules, I have this is an assignment. This is the assignment that you're gonna work on it in a group. And I already have you assigned groups, and I can actually set those groups up so that you'll know who you're with before we go. But I want you to do these questions, okay? And then go into this one. So you're going to talk about what are the risks for each one, what type of care are they going to need, and come up with a nursing problem or that nursing goal. And remember, they should be concept-based. All right. Let me see if I can show you. Let me go over here.
Since we're doing these in groups, do you want each individual person to turn it in, or do you want one person to turn it in for the group with all the names on it?
No, you should be able to, hopefully I set it up right. You should be able to turn it in as one person turns it in, and then everyone should be able to get a grade from there. Just in case, please put all of your names on the original, on the document so that I can go to each person and make sure they get their grade if I've set it up wrong. So
The assignment is locked.
okay, I'm gonna go in there right now. Sorry, I don't mean to make you dizzy here. Let's see. I'll publish these.
Can you scroll down to open exams?
Are you serious?
No, I'm not.
I'm like, I'm not that bad. Okay, so here is the assignment. So sorry, that's basically what I just showed you. This makes your eyes go crazy, sorry. Here it is. So this is the assignment, okay? And I always provide APA format on a reference page just so that you guys get used to that. You should be pretty good at it. And let me see here. What else did you need to know? I have you set in groups already. Let me go ahead and see if I can put you in your breakout rooms.
Hugo, do your thing.
I think she's got this one. She knows what she's doing.
Create. Oops. Okay, let me go to people. I know it seems silly to do this while you guys are sitting here. It's probably a waste of your time, but there is no way to do this until you guys are actually here. So, let me see here. Let me put this over here. Okay, so Mara Cruz, Crystal, David. John's not here though, right? But I'll put him in there. Oh, no, he is here.
Yeah, I'm here.
I think that's group 1. And then group 2. Is Jonathan?
Yeah.
Let me just find. Are you under a different? Is it JJ?
Yes.
Okay. Amali. And I just did these random, guys. That it's not last night. So, and Alex, you're under Alex here, right?
Yeah, that's correct.
Okay. I don't think Gwen is still here. I think they had to.
I'm still here, Mrs. Storm.
Oh, you are? Okay.
Yeah.
Amanda. My, you're okay. I got it. All right. So Claudia. Let's see, Claudia, Aaron, Margaret, Janet, and Raul. You can call those names out if you can see them. Brittany, Loida, Isaac. Okay. Getting closer, guys. I don't see. Abram, are you under in another Abram Villa? Let me see. So Abram Villa is in this group with Emily and Kenya. I don't see him here. Okay. Abram's not here, right?
He was here.
I know Francisco said they're about to start doing the shot clinic. So if he's at the shot clinic, that's probably what happened.
Oh, okay. Hugo, Nicholas, and Marco. Okay. And then the rest. Samantha. Amarani, is he? Amarani, did I give you? Are you here?
Yeah, I'm
Amarani's.
here. You're just breaking out on my end.
That's okay.
Can you hear me?
Are you under another? Are you under another name, Amarani? On your.
I shouldn't be now. I think I saw that I was in the group with JJ and Alex.
Alex, JJ. Okay, let me.
It was like, I think it was the second group.
Yeah, let me add you there. Okay. All right, so the plan is going to be, I just want to give you now just a few minutes to kind of plan out what you're going to do. And let's come back. I mean, really, you only have 10 minutes to do this, right? Is everybody clear? I'm just giving you the last 10 minutes to kind of plan out what you're going to do.
But it's not due in 10 minutes, right?
No.
Okay.
No. So no, it is not due in 10 minutes. It's due. I made it due for Sunday night at 11:59. But I was thinking this could be something that it's going to be pretty easy. I mean, if you just, all the information is between the 3 different areas. I will double check if there's any more information on Jenny, Jenny Brown. But I think that's it. Okay. I'm going to go ahead and open them now. All right. Are you guys in the rooms? Claudia, are you in your room?